Hello and welcome to episode 153 of Chairside Live. We have an amazing show for you today with an interesting case of the week. But first, Dr. Abai, how you doing?
I'm doing great. The week is going really well.
Yeah. Tomorrow is October 1st. Do you have your Halloween costume planned?
No, I have my mortgage payment planned.
Okay, yeah, that makes sense.
Yeah.
That's probably a better option at this point. But I want to do a Flintstone theme to be Fred and Wilma, and then have our daughter, for my husband and I, be Fred and Wilma, and then our daughter be Pebbles. But enough about that. What's in the case of the week?
Oh, it's going to be a really exciting case of the week. So we usually get patients that come in and they have a failing tooth, and they say, I want you to take the tooth out and I want an implant. And the traditional way of doing that is you take the tooth out, you bone graft, you wait about 4 months, and you bring the patient back, then you go through another set of surgery. With advancements in implant materials, basically, and the design of the implants, we can actually place the implants immediately sometimes, given that the patient has certain requirements to receive that implant. Nice. So for the case of the week, that's what we're going to be talking about, is extraction and immediate implant placement. So why don't we go ahead and take a look at the case of the week. Okay, so let's go ahead and take a look at this week's case of the week, and I want to talk about immediate implant placement, and in particular, immediate implant placement with the Hahn Implant. And the reason for that is Dr. Jack Hahn is one of my mentors and one of our grand poobahs in implant dentistry. He has designed this implant and the thread pattern to provide us with immediate placement stability when we place the implant. So that's going to be one of our requirements for the immediate implant or emergency implant placement. So let's go ahead and take a look at the case of the week. For this week, I actually have two cases that I want to share with you, and they are both similar scenarios where the patient comes in with a failing tooth. In these scenarios, they're both anterior teeth. For the first case, it's tooth number 7, and as you can see here, the patient has had a lot of work done on this tooth. There's a short root. The patient has undergone root canal therapy and a crown. So the crown has lasted a while, but now we're starting to get a little bit of recurrent decay underneath the existing restoration. So it was time for us to actually remove this tooth. So what I want to present to you is essentially the protocol for placing an immediate implant and when to do it and when not to do it. So in this situation, I'll go ahead and remove the tooth as atraumatically as possible. The first requirement for me is whether I was able to extract the tooth atraumatically or not. And whether I need to place any bone graft and just wait and bring the patient back, or can I go ahead and place the implant? Now in this situation, what I did was I wanted to open a flap because when I extracted the tooth, I took my periodontal probe and I probed the buccal wall and buccal shelf, and I realized that there was a little bit of a defect there. So the reason why we open a flap is to visualize the bone. And I really wanted to do a papilla sparing flap where I don't go all the way to the adjacent teeth, and I give the papilla a chance to remain where they are, and I won't have the recession after the flap. And the second requirement for me when I'm placing an immediate implant is whether I can get primary stability with my implant. So in order to do that, I go ahead and drill into the palatal wall, and I want to make sure that I have what we call a purchase point where we can go ahead and create our osteotomy and essentially create an area where the implant can be received by the bone, and there will be enough bone to be able to hold on to the implant. So in this situation, my osteotomy is completed, and I'll go ahead and place the implant. And here you can see that the implant is in place, and you have some of the threads showing. The bone level mesiodistally and proximally is going to be held up by the adjacent teeth, so I'm not worried about that. I'm utilizing some BioOs bone graft material. It's a xenograft. I'll go ahead and place the BioOs in the buccal area and also covering the implant itself. Obviously, it's not going to bond to the top of the implant, the polished titanium healing abutment, and there's a situation right before I suture the grafted site. And what I'm utilizing here is essentially it's a horizontal suture. However, it's a little bit modified, and it helps pull the tissue more coronally, and I try to create a primary closure as much as possible. In this scenario, I placed one horizontal mattress suture and interrupted sutures down the sides of the incision where I had my vertical releasing areas. And then, obviously, we want to send the patient home, but we want the patient to have a tooth there, and the patient wants to have a tooth there. So we went ahead and fabricated a removable interim restoration. This is a interim partial, and you don't want the tissue surface to be in touch with your partial. So what I usually do is I'll go ahead and check the intaglio surface, and I'll make the adjustments. So now, the patient goes through a period of healing, usually about 3 to 4 months, before I uncover the implant and place a healing abutment. The healing abutment is usually in place for several weeks before I can go ahead and fabricate a temporary and start the process of tissue contouring before we fabricate the final restoration. So the second case is very similar to the first case, except the patient came in with tooth number 8, obviously a lateral periodontal lesion in this situation. And again, it's a challenge because you have to ask yourself, can I extract this tooth atraumatically? In this situation, can I extract and remove the lateral periodontal cyst and have an area where I can go ahead and place the implant? So again, very gently working around the tooth, I'll go ahead and try to get a little bit of mobility with my periotomes. And then I'll take my time with my forceps, and I'll make sure to extract the tooth as atraumatically as possible. In this situation, just like the last, the crown is removed, and now I have a little bit more access to the tooth, and I'll go ahead and extract the tooth. So once the tooth is extracted, I'll do the same thing as I did for the last case, where I'll take my periodontal probe and I'll make sure that I have an intact buccal plate. If I don't, I'll open a flap so I can visualize it and I'll be able to graft it. If I do have my buccal shelf, I'll go ahead and proceed to the next step, which is to create that purchase point on the palatal. So here you see the tooth is extracted atraumatically, and I'll go ahead and clean out the area and remove the cyst and curette the socket as much as possible to have a nice clean socket to be able to place the implant. And as you can see here, we were able to remove the lateral periodontal cyst. And here you see that I'm probing the buccal shelf, and I have about 3 millimeters apical to my mucogingival junction to play around with and place the implant. So again, same thing. I'm going to utilize the palatal shelf in order to create that primary stability for my implant. And I'll go ahead and proceed with the steps to create the osteotomy for the implant. Now, the question is, if I create the osteotomy and I want to go ahead and place the implant, what if I don't have primary stability? Do I still place the implant? For me, I feel more comfortable if I cannot create primary stability to just graft the area and come back at a future date. So that is determined at the time of implant placement, as I'm doing here. I'll go ahead and place the implant, and I'll double check my primary stability and make sure that I maintain that before placing bone graft and suturing. So in this situation, I'll go ahead and get to the correct depth, and I'll check my primary stability. I have about 25 Newton centimeters, so it's really borderline. I'm definitely not going to load this implant, but in theory, I can go ahead and graft around it and wait and let the implant osseointegrate and come back later and create the temporary for the patient. So here's an x-ray of the implant in place. And there are certain requirements that I look for in terms of how much stability I have and how much primary stability I have at the apical end of the implant when I'm placing it. In this situation, I'm using a allograft. It's called Regeneros by Biomet. And once the allograft is in place, I'll go ahead and place the suture and deliver the temporary for the patient. So again, I'll go ahead and create my horizontal mattress, but it is a modified horizontal mattress in order to create a better seal and as close to a primary closure as possible. Obviously, this is an extraction socket, so at the center of the ridge, you're not going to create that primary closure, but The closer you can get to it, the better, obviously, for the healing. And then once I have my suture in place, I'll go ahead and place the interim partial for the patient. And again, checking the intaglio surface so that it is not touching the grafted area. So that's our case of the week, and I hope you enjoyed it.
Thank you for that, Dr. Abai.
Thank you, Megan. So we're reducing the chairside time and the clinical time, basically, with being able to place immediate implants and hopefully restoring in a 4-month period rather than an 8-month period.
I like it. It's a good advancement.
It really is.
Now let's go to a segment we call Viewer Mail. This week's viewer mail comes to us from Dr. David Spilkia, and he had just watched episode 152 of Chairside Live and said that the video showed old PFM crowns being cut off, and he noticed that number 7 had amalgam visible. He says when the impression was taken, however, the amalgam either was removed or covered. What actually was done here? My concern is that with the translucency of bruxer anterior, there would be show-through if this is not addressed. I still prefer metal posts over fiber posts, and sometimes the metal will be visible and will ruin an otherwise nice bruxer anterior crown.
Well, that's a great point. And looking at the video, you can definitely see that there is some metal showing on tooth number 7. And Megan, what you can actually do is you can use a metal opaquer to get rid of that bright metal color so that the bruxer anterior doesn't show through the stump shade, basically. The other thing you could do is you can still utilize a metal post, but do the build-up with a resin.
Okay.
And that way you have the benefit of the strength of the post and the aesthetics of the resin, and it's not going to show through in your final restoration.
And what was done on the particular case of last week's episode?
I believe that Dr. Mirsan had utilized the opaquer for that tooth.
Great.
Yeah.
All right. So yeah, that was a great question. Thank you so much, Dr. Spilkia, for writing in. And now let's go to the news.
Let's go to the news.
Okay. A Hong Kong woman got a crunchy surprise in her takeout sushi. When she bit into a piece of sushi, she felt something hard, spit it out, and much to her disgust, found a 3-unit bridge. She took some pictures and contacted the restaurant. The store manager assures them that none of its staff wears false teeth and that all employees are made to wear masks during food processing. The restaurant chain, called Sushi Express, is now under investigation by health inspectors by Hong Kong's Food and Environmental Hygiene Department.
And this is exactly why patients should get implants.
Right? See? I mean, just totally rallying for the cause here. Have you ever bit into any sort of food and found...
You know what? I was thinking about this. When I was a little kid, I went to San Francisco and I had some clam chowder. And I bit into a clamshell.
Ooh.
But English is my 3rd language, so back then I was new to the whole English thing.
Yeah.
So I told the waitress, I said, you know, I just bit into a piece of clam. And she got offended, like, what are you saying? We don't have clams in our clam chowder?
Right.
So yeah, that was my relation to the story was
Gosh.
tasty.
Yeah, you know, and we've seen many stories like this on Chairside Live where, you know, they bite into something and there's a tooth or there's a finger or whatever, just random stuff that, you know, sometimes they find out that the person actually placed it in there. But in your case, it's safe to assume that that was just an accidental shell piece left in your soup, but...
Probably an accident.
Yeah.
Probably.
Yeah. All right, well, thank you so much for that case of the week and for your comments on the news. Thank you for watching, and please come back next week for another great episode of Chairside Live.
See you next week.
Hey! What?
So you're going directly to this camera after. If you get a weird text, just don't judge me, okay?
But got it. You should make it so your text messages come up as just so it hides it.
Hey, are you at work? Yes, I'm at work.
Right.
Where else would I be?
Please keep the viewer mail coming in. We love to hear from you, and we love to give you clinical tips in the Just talking, just taking my tongue out for a ride here, just seeing what I can do.
You guys done with me?
Do you have your Halloween costume planned?
No, I have my mortgage payment planned.